move on to our next lecture of the AWR. I think Professor CP doesn't need any introduction in this August gathering, and fondly he's a mentor or a teacher or a guide for most of the surgeons of the Indian subcontinent, and we are eagerly waiting to hear Professor CP. Thank you, sir.
Yeah. Thank you for the kind words, and I thank Ramana, Shinde, and Punjani for giving this opportunity to share the title Humility and Pride of Hernia Surgeons. When we started early, when laparoscopic hernia repair not known, how much challenges we have to do, make it as a science. Today, AWR community surgeons celebrating like an international meeting here. I'm enjoyed, delighted, congratulations all the organizers and making it up. And the first laparoscopy surgery done in 92, after a gallbladder appendix done. So 24 years old male came to me, I did a plucking technique, put the mesh into the sac and closed the internal ring. After a week, the boy came asking me, "Sir, I have developed a third testis, sir," and he was appreciating me. Then all of you know what had happened to me, no? The mesh which you put into the sac migrated down to root of the scrotum looking like a testis. So I removed the mesh and told this is the truth of the patient. Then after that I went to United States for a month trip to learn the advanced laparoscopy surgery. During that time, two procedures I learned. One is McKernan taught me, how to do TAPP in a pig, thick and induced surgery. And subsequently, I also listened to Aregi talked about transabdominal periproctal repair. More than that, Nayakas, the way he gave a keynote lecture on functional anatomy of groin, oh, superb. These three things gave me, till the time no TAPP article got published. After returning back to India, while coming back, I made a mistake, or not to know, but some American told there is a cranky guy from India. When I bought this hernia stapler, costly equipment, no? I thought fixing the mesh to the Cooper's ligament, I need a mechanical device. That impression, the company told me, I also believed it, we got it. And I did the Indian first TAPP approach in 92, and subsequently, two procedures, I was doing it first few years. Before that, I was doing shoulders. So I split the transverse fascia for internal ring down to cubotubercle. I know the anatomy well, and after sweeping the entire fat and abdominal wall up to Cooper's ligament, pipiramus and this, I could place a mesh and suture it Cooper's ligament and under the fascia. So it is pre-peritoneal open approach. Modified shoulders we can call, or you can call my name also. Simple. Na? Same time I did laparoscopic TAPP approach. That time the standard mesh you all know smaller size, 11/7. So laparoscopic TAPP also, I used to fix it to all anterior wall, but Cooper's I glued the tacker and the stapler. After 150 case, 150 open, no recurrence. But TAPP, out first 50, 4 got recurred all at the medial, all these staple failed fixation. Where because I know suturing all, I did it there, no lateral recurrence at all. And I changed it to suturing to Cooper's ligament, after that no recurrence. And two things many of us tried to increase the mesh integrity, stability. We want two things. We split the mesh and accommodate the cord structures. We thought it enhances the integrity. One recurrence, I stopped that time. Similarly, my friends also in the world over should have stopped. That may be the reason also. And the internal ring, I used to do pediatric hernia from 92 itself. But simple, no? Suturing the internal ring like a hernia to me is one simple way I used to do it. But many people, pediatric surgeon told recurrence. Then I found out any internal ring dilated, just closure is not adequate, recurrence will be more. Then I thought, okay, what we are leaving behind the sac, cutting the internal sac, internal ring, conjoined cremastic to the iliopelvic tract as suture, then circumferential, no recurrence. That I presented in ELSA Congress at Singapore. So that gave me a lesson. Any internal ring comes very large, scrotal hernia, something like, I suture making a mold before placing a mesh. And once we learn potential sites for hernia formation, and size of the mesh also increased, We got it 15 by 15, trimming it to 13 by 12 and 15 by 12. That became a standard mesh. We could cover the entire myoparticular orifice with one piece of mesh. But I used to continue suture, one Cooper suture, though it is not necessary. And subsequently, some selected cases, we need additional piece of mesh to laterally. Then we made the company to make it especially for us, 18 by 13 mesh, so that even a large needed single piece we can be using it. Okay, TAPP, when I was using it, keeping the camera at the umbilicus, I found certain limitations. Umbilicus low placed or previous scar and irreducible large hernias, manipulation difficult. Then what I thought, why not enhancing it? I shifted the camera super umbilical, epigastric. It gave a wider view. I can two angulation, two working trocar. Any difficulty, any irreducible, not more, unless it is a strangulation, we were able to manage it by with wide dissection, able to do it. And that's why in the beginning, everybody used to say, sir, it looks a wider dissection. But after 3 years, I shifted to TEP. And TEP, when I shifted, my convinced look, after that time, looking at Duluc and my friends, everybody. When I'm shifting it, and a total endoscopy technique, and 95 to 2000 completely changed 2000, TEP became the standard approach in our center. You all know McKernan technique is the best technique everybody practiced world over, no doubt about it, but his working trocars in the midline between symphysis and umbilicus, lacking triangulation. That's why I did not convince. He taught me but to 92, but I didn't take it up. But when I 95 went for it, I made it because when maneuverability is difficult, that means irreducible hernias, excision of the indirect sac, obliterating pseudosac, preventing seroma. I always recommend mesh suture. So that is difficult in McKernan technique. Then what I said, see, this can appreciate things. The first picture is a McKernan, you can hear. Second is, this is mine, camera at the umbilicus, working trocars lateral. This is E-TEP by George D. is my friend who made it that one. Here, what is the difference? Mine approach. I keep the camera trocar between the rectus muscle and protractor sheath. And we don't use balloon. It is 0 degree telescopic movement with insufflation, goes between the two layers of the lamina. That is, it is not a preperitoneal, it is extrafacial. Working trocars at the linear similar level, cranial to the arcuate. So I have a two angle technique. See, small video clipping you can appreciate. We don't use to reduce the cost. Wherever possible, use it. That's why I use a reusable trocar. I take it a stitch. The trocar will not slip out. Now you can appreciate here. By moving, now you can appreciate the post-rectus sheath. See, this is a post-rectus sheath, and identifying it. Then we make a 5mm trocar, cranial to the arcuate level. That is very important. And this is, you can line, I marked it arcuate level, it is. Subsequently work on the left side. If it is bilateral, make it little more dissection on, make it exactly like a mirror angle, opposite side. And if we have a two, see, exactly we're marking it here, so that we'll have a two hand working. And like any other, this triangulation is there, very important, see, marking it. Now look at here, even from the pubic tubercle you measure it, it is adequate length is there. One wanted to do a larger size mesh, they can place a mesh accordingly. That's why look at, this is a triangulation which we described in 95, we went in. So now you can appreciate how the two hand works. This is the left side we are working it, there is a hernial sac, you can appreciate. The transverse fascia at the lower end, internal ring level is deficient, similarly also the midline and symphysis pubis is deficient. So you can go to progress space very easily, you can go to that deficient level. Now you can appreciate both ramus has been exposed. Now we go to the right side, parallelization we do it, taking the sac from the cord structures and adequately has to be complete parallelization, very important if you want to keep a good size mesh. Now the right side is done, left side also we can look at something more if we need to be done, we have to take it up. We should not hold the vas deferens any time. That is, you can see the umbilical folded vessels also. So it has been done. Now we take it a standard mesh is 15 by 12. We place it. We folding technique like a banana leaves, what I call, even book described. Banana leaves very easy to open. No need to tie it and like a cigarette rolling it. and for which those days mesh spreader they used to spend, and I didn't use it. Now we look at the left side. Now go to the right side. Folding, unfolding is very easy, and one suture, not necessary, but still for my juniors to learn, this suturing is I give them opportunity to make it up. Then subsequently we take it out the thread. Then you can check it. We should not get, when deflating it, you should nicely come across. That is very, very important. Even a couple of cases, we have to second day, I have to do it, put it back again, I have to do it, because hurriedly when do it is a problem. And this is the technique, our center, we have a 7 group, GEM group is 7 hospitals, all my trained surgeons across India, they are doing the same. And the last study 30,000 cases, 25 years, and consultant, residents, everybody does in our centers, and 0.1% recurrence. And my own personal hernia, when I had hernia, my young surgeon learned the technique from me and did the same to me successfully, and it was done in the previous evening, and evening late, morning 7 o'clock, I was in the OT to operate. To say that how fast recovery, my personal aim itself, I checked it. Not like that, how recovery cost. Many surgeons used to say, costly, cannot be duplicated. This is what the first 10 years was their challenge I have to face everybody. Then what I did, 2000, wanted to celebrate my own hospital. Okay, I collected all the free patients and operated one day, morning to night, how many I can do it. 34 cases hernia operated, calling more than 100 surgeons were there in the auditorium, seeing skin to skin every surgery. Next day, all the patients say picnic like went, and it all well appreciated. To say one can do free, that means cheaper. In front of every surgeon showed how fast. Some people come all, such a open surgery will take, laparoscopic looks faster. That's what the surgeon commented, and it went through. Then, this I showed in a World Congress at Rome, all types, open, tap. Immediately I got an invitation to go to Buenos Aires, Argentina to demonstrate live operation during the Latin American Federal Congress in 2000. And there are some difficult cases, long-standing cases, momentum get hypertrophy, you can't take it into the canal, you have to divide it in the sac, remove through root of scrotum, you need a small incision, similarly sac also can be excised, then regular laparoscopic mesh like you can place it, the patient gets the same advantage. But I call it as a lap-assisted herniaplasty, we published the article also. And for ventral hernia, I was following like a LeBlanc's technique using cortex mesh. And they used to takers, I found that cortex, you all know, thick. Putting the takers will not hold so well. What I did, I started suturing all around. I'm happy, but still, I'm not so convinced of the cortex mesh. Very limited number of cases I did. But this is one I tell you, I was called to Andhra Pradesh chapter nearby. Tirupati is a very world famous temple. That is the place where workshop was. I was asked to do it, hernia demonstration in front of audience live like this. There, no cortex mesh, no takers. They asked me to do it. It is sister of a professor organizing chairman. So I have to do it. What I did, I took the peritoneal flap and continued suture the defect, and proline mesh also fixed, and again covered the peritoneal flap. Fortunately, it was the lower abdominal hernia. And but suturing for us, everybody knows. And I started suturing some closure 92. Subsequently extended to GGA, cholecystogastrum, everything. When I showed in 95 Luxembourg, everybody started calling because I used a conventional needle, just widening, put inside, and whatever suture comes, I will doing it. That's why Indian doing is open suturing, laparoscopic suturing looks same. That is the first comment was made. Even the first Whipple, when I did it at Coimbatore, pancreatitis, I did it at suturing. So that's why this abdominal wall closure was not difficult for us doing it. And here, luckily the Bombay company got a Paretex mesh from France and gave us, we got excited, all the midline sutures, midline hernias, we started doing it well, and all sutures, no takers. See here, that time, and no suture available in company, whatever the open available sutures I will be, see, you look at loop ethylene, what I use doing open surgery, abdominal closure, I am using it here. You can appreciate it is possible this way. And go around any length of suture, no problem. And after that we pull and take this thread outside, then tying it outside initially because laparoscopic tying is a little difficult that time. Now, of course, later we learn to doing it. And this is where paratus mesh we can build attacking sutures in the midline, upper end subsequently. This is what I was using it before, see, and fixing up all round. In preventive seromol, they can suture it and this here. When I demonstrated this live surgery 2002 at Coimbatore during laparoscopy, there were thousands of surgeons and so much excited to see something new when shown. When I wrote my first Atlas book, I wrote it at the same chapter. Subsequently also, when I bought Hernia first manual, there the chapter came, and Korean Hernia Society published my hernia book in their language, their chapter goes in them. And after 720 cases, I presented my experience in AHS Boston. There, the recurrence rate 0.6% compared to average 4% other series. Seroma, very less. No pseudo bulge because suturing done. And also, rectus muscle come to the midline. Functionally, the ladies finding very good. When I said just my ladies are very happy to work, then the comment from the organizer came, no sir, it is because muscle comes to midline, functionally it is better. That's why you're taking more appreciable because improved functional. And not only that, after the American College of Surgeons wanted to bring Atlas, they asked me to write the chapter, how I do it, suturing the defect in placing a mesh. It came in 2008. And Professor Kukleta, I think my friend is here. This is gentleman made the IPOM plus. When my article came in 2007 Hernia Journal and he was commenting on, looks nice, very good, he tracked it. He was like fun making it, IPOM blue, IPOM plus. I call this augmented herniaplasty. Fun you making it, he wrote an article in 2010 making IPOM plus. Now you know the IPOM plus, the birth price is Coimbatore. Another thing, Indian ladies, abdomen is so flabby, divarication very common. Then the ladies himself taught me, Indian ladies have a violet, no? Pull the thread, it closes. Simple way, why not you placate the linea alba inside, laparoscopy. See, look at, those days I was struggling. Now we have a wheel of wonderful switches and you can see this was demonstrated live 4 years before our laparoscopic hernia carnival and Chennai only. You can appreciate it is a non-absorbable suture, very nicely it's going. And after that we place a mesh. It is a 15 centimeters linea alba. This is symptomatic. If you don't operate, the patient says, sir, other ladies calling me, are you pregnant or not? Such a symptom much more than more. It is not cosmetic, it is excellent after that mesh. And more than that, more important, Japanese article came, two things they said. When you bring the muscle, either divarication or incisional hernia, and functionally muscle improves, creates a physiologic tension more, muscle hypertrophy strength becomes much better. And another problem is when you deal with large hernias and you can't put the content inside, that time TAR was not explained, we did not know. And Botox injection also not available in India, we did not know what I used. I used a Viciport, take it into between the scarpus fascia and the external big aponeurosis. And this also live surgery demonstrated, I think last laparoscopy at Coimbatore. See, I am making it, see Excel trocar, placing it, and you can appreciate here. This is not subcutaneous plane, and I think Shinde was appreciated so much there. It is between scarpus fascia and external oblique aponeurosis. That means need not worry about seroma, and it is. Now you can see simple instrument. I made a 5mm trocar by side of the camera port, taking a dissection. Entire up to iliopelvic tract, the caudally, laterally up to mid-axial line. So widely you can make it, and magnification tells you whether now neurovascular bundle or not to divide about. Now we incise the external oblique approach with hook is dividing the roof and the floor, but other techniques has been described between the internal oblique and the external oblique, then to go divide the roof. Now you can, the pneumo separates the external oblique approach so well. And not only that, we do dissect either side of the external oblique aponeurosis, widest muscle give relaxation, it gives way. Okay, I want up time, I will faster. Okay. Then this article by George Dees made a wonderful revolutionary. He made it for initially groin, later it is been turned towards ventral hernia. And Iger, Belyansky and these two articles, I think we have to appreciate them wonderfully, how that revolution for ventral hernia made it up. But initially port for upper hernia, they make it a bottom in trocars, lower abdomen and bottom up. And the lower abdomen, they make it a cranial ports at the upper setup, go down, cranial down approach. But somewhere I tried few cases, I was not convinced because that way. Then what I made a triangulation, like making a 3 trocars. I am a right-handed, so I stand on the left side. If you are left-handed, you can go to the other side. Central camera, working trocar on either side. The red dot is, if it is a complex hernia lower, make it up. And if it is a complex hernia up, make it another 5 mm. You can work out surgically. All midline hernias can be dealt here. So this is the port you can appreciate. Axial trocar, we go up to this external, now you can see muscle, and I am between the rectus muscle here. Then after creating a space, now we will go making it up to linea alba we will go, this most important technique I will show here. See, once the left post rectus is taken up, I go crossing over other side. This is right post rectus and go up to the linea simulnaris, come back. So alternately you can do it. Now this is a patient has got hernia combined divarication, and this is gives for me to work comfortably here. I can go into the peritoneal cavity, a bowel to be released, we can do it, additions, everything can be done, and again you continue, then reconstruct it here. So taking down completely, dropping all this, now you can see here. Combined inguinal hernia, you can take it up. The closure of the post rectus is very important, otherwise that herniation can occur, it is become a problem. Proper suturing, we have crossed 1,000 cases, I have not come across any of the post rectus sheath. We had a problem like hematoma, other things not here. So after that we take it, initially I used absorbable, here is a non-absorbable PPT, and you can appreciate here. Assisting surgeon or left hand we can push inside, take it up, and it is like a divarication which I showed you. See, now placing a vertical and a horizontal, you pick it up, no drainage, selectively put it, if it's traumatic then we will put a drain. And we did a first initial study, made a 254 cases, single center study, and we found it is better than IPOM as far as regular mesh, cost and everything, but one concern difficult to learn how that is. We also did a prospective study comparing E-TEP and IPOM plus, and we found IPOM E-TEP scores over IPOM plus. And large hernias, if you think if you have to reduce, you can't do it, and we need a TAR. If a same opposite side TAR, same trocar what I shown. If you want to be same side, you have to make it additional 2 trocars opposite side making it up. But lateral abdominal hernias, I group into group 1, 2, 3 like. If it is any one involving linea simulnaris or within 5 centimeter, contralateral trocar as I shown now. But if it is lateral, for example, this is involving linea alba within. Suppose if it is laterally away 5 centimeter, then ipsilateral trocar is adequate for E-TEP. Suppose if it is even posterior lumbar traumatic or primary, this is where. I will show a small video. See, look at iliac crust done, peritonitis, ileal resection done, this is a case. Ipsilateral trocar, we are making it axial trocar, and we make it 2 working trocars here like this. Now see, I want to the defect here, we can appreciate here. So after that we always try to suture as far as possible, and except very few we have done almost suturing it, even otherwise we will do donning, otherwise the mesh will not stay there, laterally bulge should not be there, patient comes mainly for bulge. After suturing it we place a mesh. Then the last video clipping, you can see 5 mm trocar on the left side made to see this defect, then ipsilateral trocar I am making it on the right hernia, external this now you can see I am making it up. Now we are making a vertical 2 working trocars either side. Taking down the rectus posteriorly. Laterally you can see the nerves very nicely. Magnification, now that's why I recommend always have a good clarity cameras if you want to do a TAR, so that no injury will not be there. Now I started doing a TAR. Now go laterally. So now we are reaching the defect. You can appreciate. Those the patient came with only big bulge. Now you can see the upper intercostal margin, diaphragm also we can go taken down. See, like here. Then again, defect, peritoneal defect we closed. Then we go the closure of these with the normal sutures. Then we place a mesh. You can see intercostal margin, diaphragm also we taken out and the E-TEP. And this technique is very nicely, and here I was showing them our juniors, if you can suture it, otherwise also observable takers are available now, pre-secured strap and so on. Now it is motorized, we released, it is a wonderful one, we can use it. Okay. So again, last 2 minutes, the hiatus is anybody afraid of mesh.
Can we make it one, please?
Yeah.
Sorry, Dr. Palanivelu. Sorry, can we make it one? We're running almost 15
Yeah,
minutes.
I will finish it. Yeah. Okay. So I think I will go then. This is the 4th edition volume. You have been seeing it. And I invite all of you to come to Coimbatore for a laparoscopic carnival. And this is standardization of all procedure, labs, hernia safe, labs, galley safe, and like this. This is a guts book, released biography. And I'll take a last word using it. Operating hernia without recurrence, making them to work faster, I consider it the greatest service to the community. I appreciate all of your interest in hernia surgery. Wish you all the best. Thank you very much.